Diabetes management. A legal disclaimer we put at the beginning of all of our presentations. This information is for general and educational use only. Content is not intended to substitute for professional, legal, or clinical advice. We strive to keep our information as accurate and timely as possible, but make no promises and guarantees it works for your local unique situation. As an introduction, managing diabetes during pregnancy is vital for the mom and baby's health. Uncontrolled diabetes poses risk, making early detection, management, and education by midwives essential. Their care helps prevent complications and supports the best outcomes for moms and babies. There's different types of diabetes in pregnancies. We're going to go to the basics of all the definitions. There's pre-existing diabetes, chronic diabetes. They had it before the pregnancy. Type 1 is typically autoimmune condition requiring insulin therapy for blood sugar control. The pancreas is not making enough insulin. It's more of a genetic autoimmune condition. It used to be called childhood diabetes, but they don't use that term much anymore because so many kids are getting type 2 diabetes now because of our lifestyle, our obesity, our food. So type 2 diabetes used to be more older people, but we have such a challenge in the United States right now with type 2 diabetes. That's a metabolic disorder where the insulin is ineffective. The body has produced so much insulin to combat all the sugar in the food that they're eating that it gets tired. It just can't produce insulin like it used to. It can be managed sometimes through lifestyle changes, but sometimes you also need to do oral meds or even insulin. Diet and exercise, keeping a close eye on A1C levels. Once you get the diagnosis of diabetes, it never goes away, but you can control it and manage it. So anybody that has diabetes before pregnancy, before 20 weeks gestation diagnosis is chronic diabetes, and it is managed slightly different, more higher risk than pregnancy diabetes. So definitely an obstetrician, higher risk, close management of midwifery services. Gestational diabetes, GDM, develops in the second and third trimester due to, a lot of times, the placenta is just affecting that insulin production by the body. So you're getting some insulin resistance, you're getting some production challenges, and it usually resolves after the placenta is separated and the woman's no longer pregnant and has that stressor in her body. But I always stress to people that when you have gestational diabetes, it increases your chances of type 2 diabetes in the next 10 years really up there, just like hypertension does and blood pressure issues. So if your body is already stressed and tipping the scale during pregnancy that the sugars are getting elevated, you have a much higher chance of getting chronic diabetes years to come after the delivery. So the role of the midwife during diabetes management, our goal is to provide screenings, monitoring, education, and collaborate with a specialist within the healthcare system. Depending on your educational background, if you are a certified nurse midwife, you're going to have a little more skills and access to resources for your families in regards to oral medications, glyburide, insulin, getting prescriptions for monitoring stuff versus they have to buy it over the counter. Getting lab work done, some direct entry certified professional midwives has challenges with that. So depending on your local area will dictate the scope of practice and how the midwife manages within her local community. Screening and early detection, so it is recommended at well-woman visits, preconception counseling, to do an A1C, to do a random blood sugar, to do a fasting, and just get a sense of this woman's baseline and her risk factors, and what is her average meals and family history and exercise look like. And then during pregnancy, if they've had a history of big babies, they've had a history of diabetes during pregnancy, they're obese, there's other risk factors. Many practices will do on the new OB screening labs, A1C or glucose, the tolerance test. But if they're low risk and healthy, they'll typically do at 24 to 28 weeks gestation. The oral glucose testing, there's a 1 hour, there's a 2 hour, there's a 3 hour. The diabetes screenings is a little complicated because there's many organizations and they kind of have different perspectives and sometimes contradict each other. So I've worked so many places across the country, and as long as they're screening, some places will just do the 3 hours at 24 weeks. Everybody will get a random blood sugar with their new OB and get the glucose testing at 24 to 28 weeks. Some practices, particularly birth center home birth practices, they can do alternative screenings. They can do home monitoring of their blood sugars for a week. They can do jelly beans that are equivalent to the sugar that's in that glucose test. Like, there's our goal is to screen and do the best of our ability based on the culture, the beliefs, the financial resources, the choices that our families want to have. And there are some criteria if they are under 25, normal body mass index, no family history of diabetes, no pregnancies, personal history of diabetes, no large babies. There are criteria that they can decline the diabetes screening. It's pretty rare in the medical system that's even discussed and brought up, but there are criteria based on the diabetes screening profiles during pregnancy that you can use. So you just have to look at your situation, the population you're serving. More and more people are obese and have chronic conditions during pregnancy, so we're getting less and less low risk moms having babies. The glucose monitoring, there's different ways. There's self-monitoring. There's a machine you can get that's continuous monitoring. You can get different times of the day. You can get the fasting if it's been at least 8 hours before eating, first thing in the morning, postprandial, 1 hour, 2 hours after eating from the time of when they started the food, their insulin adjustments, their lifestyle, and keeping a close eye on things and seeing what's helping. Because sometimes you can have diet control, gestational diabetes, and sometimes you have to get medications involved. So there's simple things that pretty much work for every chronic medical condition. We want to get our bodies healthier. We want to get to the stressors. We want to sleep well. We want to decrease the stresses. We want to do calorie counting, carbohydrates to protein ratios, not go too long without eating, being very careful of sugars, even if they're healthy sugars with apples and fruits. During diabetes, the insulin production isn't there. Your sugar is still going to spike in the body. That's where the risk comes from. I always stress to people, it's not the label of getting diabetes, it's the elevated blood sugars in your body that cause complications for you and the baby. And so the baby tries to make up for your insulin, and that's why a lot of these babies need to be watched closely after delivery, because their blood sugars are going to be low because they're used to being inside of you and compensating for your elevated blood sugars as well as what your body's trying to do. So it's not just looking at pregnancy, but also postpartum for the mother and baby with these diabetes diagnosis. Exercise, eating well, staying healthy, consistent things to do. Sometimes you'll get a diabetes educator, a nutritionist involved, get them a trainer, get some support groups, help them with resources. Maybe they're having challenges because it is more expensive to eat healthy versus processed foods. So there may be some WIC programs, some food assistance options in your area. So just getting to the root cause of lifestyle modifications that may be a barrier for them. Medication management, there may be situations where they're super high risk, they've had chronic diabetes, their A1C is through the roof, and we can't wait to try lifestyle. We're going to do the lifestyle in conjunction with the medications. If we've tried the lifestyle changes, they tend to do oral and then insulin. But if you've got somebody really, really sick and high risk, they tend to just go right to the insulin. So there's different ways, and it's definitely you want to be involved with an obstetrician. Certified nurse midwives can do oral meds, and if it's well controlled, in many states can do out-of-hospital births for these moms. But once you start doing an insulin and they're not well controlled, that's when the complications occur, and they should be delivering in the hospital. Monitoring for complications, serial growth ultrasounds. Some practices will do biophysical profiles, non-stress tests starting at 32 weeks, and just looking at the situation. Is her blood sugar well controlled? How compliant is she with prenatal care? When was the diagnosis? How severe are the labs? If she's a little bit elevated versus critically elevated. History of big babies, chronic diabetes versus gestational diabetes, they all have different impacts on the complications. Some of the complications are macrosomia, big baby, birth trauma, shoulder dystocia, cesarean section, low blood sugars after delivery with the baby, higher amounts of water, so polyhydramnios, preterm birth risk, especially if it's a bigger baby, or excessive water because the uterus hits a max size and then those receptor sites kick in to start contracting. So managing postpartum, you want to keep an eye on mom and baby closely, especially the baby the first 24, 48 hours, checking blood sugars, watching for signs of low blood sugar on the baby, keeping an eye on mom's blood sugar. A lot of times they'll do 4 to 6 weeks postpartum, a blood sugar check to see if they need to be still on meds, to see if they need to be referred to a primary care provider, and continue keeping an eye on things, and then good education about their long-term risk of chronic diabetes, even if it was just during the pregnancy and it's resolved. Mental health support, like if there's stressors in their life that are impacting the diabetes, definitely want to help with that. So as collaborative care, midwives, there's certain things we can manage independently, and many times with diabetes, depending on how simple or complicated, diet-controlled and oral medications typically can be independent of nurse midwives, and then if it's just diet-controlled, a certified professional midwife, direct entry midwife. But once you start getting into insulin, you start getting into complicated, you start getting into chronic diabetes versus pregnancy diabetes, you definitely want an endocrinologist and an obstetrician involved, co-manage, considering delivery in the hospital. Maybe they're just 100% seen by the doctor and you're filling in your role as a midwife as social support. So we just have to look at the situation that's with the mother and what her goals and preferences are for this pregnancy. So as an overall conclusion, midwives play a key role in diabetes management during pregnancy, before pregnancy, and after. We do a lot of education, support, guidance, and just individualized decision making based on their unique situation. So we definitely want to improve and empower their lifestyle changes, eating well, exercises. If they need to take some medications, talking about the options, timing of it, keeping an eye on their blood sugars, collaborating with us, maybe switching to insulin versus oral, what are the potential complications for mom and baby, and when to get an obstetrician endocrinologist involved versus this is something that, okay, just diet and exercise, yes, they've got the gestational diabetes label, but their blood sugars have been perfect on the monitoring, they've been sleeping well, they've been exercising, they've been eating great, so the blood sugars are within the normal limits. We can continue care as midwives independently and have much more lower risk of complications compared to someone that is on insulin. Their blood sugars, they're not checking them, they're really, really high, they're super sick, they're not making lifestyle changes. You definitely want to collaborate appropriately.